I'm going to do a little bit of why integrated care, even though I'm saying we are going from why really to how and who. The movement to how and who is being driven by all the government health systems, the VA, state Medicaid programs, federally qualified health centers. In other words, the drive from the federal government, from major health systems and from states is very powerful because of the impact that integrated care is showing on cost and quality, particularly now that we have a number of settings, number of systems that are maturing. When they start out, it's not the most efficient thing to do, but as you get going and as people learn how to practice in integrated settings, the payoffs in the total cost of care are substantial. It is also, to some degree, becoming the latest rage. And latest rage means that anybody who has any behavioral health connected to any kind of medical service is likely to say they're integrated. The term becomes something that people just say, oh yes, we're integrated. There's actually standards. There's definitions, and most of those folks aren't. And so we'll talk a little bit about that area today. But one of the things I want to stress is that integration is not the goal. Better health care for our patients is the goal. And I think that well done integration is a way to get there. But if something else was better, I'd be pushing that. Yes, you know that there's a lot of behavioral health need in primary care. I don't need to tell you that. This is these are somewhat old numbers, I have to say. This group, the PHQ 3000, was a study of 3,000 people who were matched to the overall population of the US. And so this is sort of, if you walk into any, down the street, in any place, on average, these are the rates you're going to encounter. In New Hampshire, these are the rates. New Hampshire is the highest binge drinking state in the country. It's nice to have a record of something, right? And Marillac 500 was 500 sequential patients in a safety net clinic in Grand Junction, Colorado. And what you see is that 2 to 3 times the rate of behavioral health needs. As populations get stressed, I know I'm not telling you anything, the level of behavioral health needs goes up. And when I show this to a lot of folks who work in these safety net clinics and say any 52% have mental health or substance abuse diagnosis, they say, where is it that low? It's very common to be higher. It's important to keep in mind, particularly in people who are in the mental health world, that most people who have behavioral health needs will not accept a referral to the specialty mental health system, to the mental health center. And so, oh, you can only see one of them. Okay. When you say, if you're a primary care provider in most places, you have, I think you have depression here. We have a screen, for instance. We gave you let's say we give you the PHQ-9, and we say, you're scoring pretty high on this. I'm concerned that you have depression. I'd like you to go to the mental health center and get some care the chances of people going is well below 50%. And in some places, it's more like 20%. That's before they get to how overburdened the mental health center is, and what the wait time is, and the whole new set of insurance issues and all of that. So screening in primary care and then saying someone go to the specialty mental health center isn't a program. And in fact, the United States Preventive Service Task Force would advise you not to screen if that's all you got. That doesn't count to them as a program. And when we think about equity in care, we have to be aware that racial and ethnic minorities are even less inclined than whites to go to specialty mental health, and they prefer, as a group, getting care in primary care. And so if you're interested in health equity, that's another piece of why behavioral health needs to be in primary care. But it's not just mental health and substance abuse. So this is the top 10 complaints that drive people to adult primary care. And chest pain, back pain, fatigue, shortness of breath, dizziness, insomnia, headache, abdominal pain, swelling, and numbness. And in this study, which was a big study, they went to the provider later, and they went to the health record and said, so in what percentage of these cases was an organic pathology found, either on exam or on a test? Anything wrong? And the answer was 15%. So 85% of these folks had no findings. That doesn't mean that they were all somatizing. That's a big word. What they were all is people who go to primary care. And, but it means that the issues of stress and life pressures and knowledge about your illness and so forth, all of these behavioral factors are major in people's utilization. This is, you are not supposed to read all these numbers. You are to look at them and say, oh, that's a lot of numbers. But what the numbers say is, this is a comparison of these are just chronic illnesses here, and of the cost of people on Medicaid per year for those with mental health and substance abuse comorbidity and those without. And when you total it all up, for 100,000 people on Medicaid, this is in one New England state, for 1 year, the additional cost for people who have mental health or substance abuse diagnosis is $535 million. My friend Steve Mellick made this slide. He is, I guess he's the country's best known consulting actuary on integrated care. And he calls this our opportunity for integrated care. That we're not going to go get all that $535 million, but that's what's out there to, if you could address all of the mental health and substance abuse comorbidities in primary care. And it's not just the medical cost. So I got this slide from Eduardo Sanchez, who at the time was the chief medical officer of Blue Cross in Texas. And Dr. Sanchez wanted to point out that all this that we've been talking about, the medical costs, which is, this includes pharmacy, it includes mental health, it's the whole ball of wax, is only 25% of the cost to employers of poor employee health. 75% of it is absenteeism and presenteeism. Presenteeism is a technical term in the occupational health world, which means I'm there, but I ain't doing much. You know, I just don't feel like it today, and I'm not sure my babysitter's going to stay, and I think I need to leave work to go get see the doctor, and all of those costs. So if you put those costs into the picture, what you find is that to employers and the cost of employee health, depression is the most expensive illness. And by far the most expensive illness. Cancer's down here. You notice the orange is the actual medical cost. Cancer's a lot more than depression. But in terms of the whole cost, depression is the most expensive illness for employers. Plus, you know, and I know, that there's a behavioral health component for almost every chronic illness. You're going to have, if you're depressed and you have arthritis, your likelihood of doing the moving you need to do or to taking the therapies or the medicines go down. Asthma, how are you going to have an asthma program without smoking cessation? How are you going to have an asthma program for children without smoking cessation for adults? And so in each of these, there's a substantial behavioral health piece if you're really going to do a whole complete program for that chronic illness. So this is a hierarchy of ways that behavioral health and medical services relate to each other. It's a set of categories that I came up with, but it has proved to be durable. And so they're using them in a number of places. SAMHSA created a 6-level way of rating integration, and they essentially put 2 subcategories in each of these to do it. So, but if you're thinking about it, let's just do these. So coordinated care would be behavioral services by referral in a different setting than the medical services, with some sort of formalized agreement about exchange of information. A release on each individual patient that you could do anywhere doesn't count as coordinated. That's just release-driven attempt to share information. I'm going to talk more about each of these. Co-located is 2 services in the same space. So, and by same space, I don't mean upstairs. I mean in the same space. As soon as you go upstairs, the utilization and the connection falls off dramatically. I've been in practices where they had a 6-month waiting list for their own service upstairs. And they also had a 50% no-show rate because after 6 months, nobody's coming, right? So co-located is in the same set of offices, but it's by referral. So we have a mental health or behavioral health service, and we have a medical service, and they refer to each other. Integrated is where there is one treatment plan, and it has a medical component, and it has a behavioral health component, and it may have other components, may have a nutrition component, but it's one treatment plan, and it's the patient's perception is that I have one treatment plan. And mostly, the patient's perception is these other people are on my provider's team. They work with my provider. And that's what gives us credibility, us behavioral health folks, credibility that we're on the team with the provider. So here's coordinated care. There's not a lot of evidence that it increases effectiveness or lowers costs, but then there are not many programs out there that have achieved basic coordinated care. So how could you not have appointment arrival notification? If I refer you to the mental health center, then when you get there, they will let me know that you came, right? No, they won't. I assume you use the term black hole when you talk about mental health services. Many do. Patients go in and no information comes out. There should be an exchange protocol. So releases would be automatic. The diagnosis problem list and med lists would have to be coordinated so that how could you prescribe in mental health without knowing the primary care med list and vice versa, and have an agreement for how we're going to coordinate, so that if you call your colleague in the mental health center or in the health center to say, I'm concerned about a medication interaction, you get that colleague because they know you might be calling. You're part of their world. They understand you as a partner somehow. This is a model that PCPs, but particularly state health planners, think of first, because they want to conserve their number of, their resources. So they'll say, the mental health center, you guys, you work with the medical, you work it out. And it tends not to work. This is co-located care. Remember, this is same place, but by referral, 2 different services. And so the doctors will say at the time of referral, by the way, I use the word doctor because the patients use the word doctor. That's my doctor. Mostly, no matter who their provider is. So when I say physician, I mean physician. When I say doctor, I mean PCPs. So the doctor will say, I'm going to refer you to behavioral health. Whoops. So access is greatly improved, substantially improved. In a study in New Hampshire, they had the same group of therapists available for elderly people diagnosed as depression, and sometimes to a random group was assigned to see those therapists in the practice site, and a random group was assigned to see those therapists in the mental health center, and they would provide a ride to the mental health center so that there was absolutely no problem. They had handled all that stuff, and they had a 50% better uptake just for being located in primary care. So access is greatly improved. Patient satisfaction and provider satisfaction goes up. Everybody, all the providers think, oh, thank God, somebody's here. I can get help with this. Outcomes go up somewhat. The problem is if the people in the space are practicing like they would in their offices, their mental health offices, pretty quickly you have the issues of referrals that don't show up, the issues of the caseload fills up. I mean, if you have X utilization of people going from primary care practice A to mental health service practice B, and now you move that into primary care and the utilization is now 2X, all of a sudden these folks, the behavioral health folks, are swamped. And if they're seeing people every hour, they have no chance of keeping up. And when they stop keeping up, they start to get a waiting list, and the providers start saying, why did we do all this? We had all these meetings, and we carved out space for these people, and now they come in and they won't see the patients in the practice. And so many of those programs end, and they don't end pleasantly, because the behavioral health folks feel unwelcome, feel like people weren't nice to them, and the providers feel like they didn't do what they said they were going to do. They couldn't see our patients. And communication is still difficult, because behavioral health folks want to see people hour for hour for hour, and then talk at the end of the day, and they don't, therefore, because they're in their offices, they don't see people in the hall, and therefore the docs are wrapping up at the end of the day, and so it doesn't really increase the fact that they share the medical record. If they do that, that helps a good deal, but it's still a problem. Now here's one step. You have to take a step toward integration from co-location to start making it work. This was a study we did in a FQHC with a brand new behavioral health person there for the first time. And I said to him, this was Nicholas Apostolaris, I said, Nicholas, I want to know every first visit that you have on your schedule, and I want to know whether the person showed up, and I want to know whether you were introduced before that. And the answer turned out to be that it was about double the rate of showing up for the first scheduled visit if he had been introduced to the patient previously by the PCP. Integrated care comes in a couple of models now that are common, as well as every possible step in between. So when I'm describing this, doesn't mean everybody out there looks like this. But the collaborative care model developed out of the University of Washington and was essentially taking the old chronic care model and doing it for depression. So it's focused on a particular illness. You screen to find out who's depressed. You begin with patient education. This person, this clinician care manager, or depression clinical specialist, they started calling them later, was initially nurses. And they were nurses that had a rigorous training program to do this. When they started to spread it to other places, the rigorous training program didn't go along. And so they tended to switch from nurses to social workers and psychologists. It tended to work better to have someone who was able to do this brief structured psychotherapy, which is a piece of it. The primary care physician is important, and the team psychiatric clinician is important. And they draw it this way. So the patient has a lot of connection with this depression clinical specialist or care manager, and who is on a registry. The registry says who the people are in the group of folks who are depressed and where they stand in their treatment. And so because we're monitoring their score on the PHQ-9, we know if they're getting better or if they're not. And the medical provider is, of course, actively involved with the patient. The psychiatric consultant is likely not involved with the patient very much in this model. They are much more involved with the behavioral care manager and with the medical provider in consulting. This psychiatric consultant role takes some real shift for people who are trained to be psychiatric clinicians. you end up treating patients without seeing them. That's very hard for many people who have been trained that you're now responsible for this case. If you're having any input on a case, you are responsible, and so you better see them, and you better be your analysis and your assessment. Not in this model. In this model, you're backing up the primary care person and the behavioral health person. The treatment plans are done fairly quickly and with limited information. So we're not going to go back and do an hour and a half seeing the patient and getting ourselves oriented. I mean, one of the things that's different in primary care, by the way, is if you're in mental health and someone walks in the door, you don't know that person. You have a lot of work to do to catch up. In primary care, we know the person. They're ours. So family history, we got it. Medical history's in the chart. So, but this is hard enough for psychiatric clinicians that the training program for that role is ongoing. Let's see if we have the AIMS Center. No, I don't have the AIMS Center here. But the AIMS Center at the University of Washington has an online asynchronous training for free for psychiatric clinicians in how to do this model. And at the American Psychiatric Association, they also are there every year giving the course because the people realize, funders realize, this is not a thing that someone can just decide, okay, I'll do that, because they have been culturally taught to do it very differently. And it needs to be taught by someone who has credibility. So someone like me, psychologist, I will not be able to teach that course because I wouldn't have any credibility. This was the first run of the difference between regular care and care in the CCM model. This is 6 months, no, this is 3 months, 6 months, and 12 months. And what you see is the results are more durable and substantially different. This is now the other model of primary care in behavioral health. And this picture starts out because this is a real picture. BHC stands for Behavioral Health Consultant. I like to say Behavioral Health Clinician because your role really is broader than just consulting. One of the reasons the term consultant was used was to begin to change the mindset of both the behavioral people and the medical people about the idea of just referring. You know, we'll bring in so-and-so, the behavioral health person, and now it's your patient. And so to get both the provider and the behavioral health person past that idea, they stick to the word consultant. I think once you get going, behavioral health clinician works fine. So you're managing the psychosocial aspects of chronic and acute diseases. You're applying behavioral health principles to address lifestyle and health risks. And you're consulting and co-managing the treatment of mental disorders and psychosocial issues. You aren't the manager of all the behavioral health things. And the goal is to return the patient so in a state in which the PCP can manage the behavioral health issues. This is both a real architectural drawing and a metaphor. This is from the Cherokee Health System's flagship health center in Knoxville, Tennessee. And you see how they built this. Here's the behavioral health consultant's office. On each side, there are 3 exam rooms, and this little thing is a shelf. And the doctor and the MA do their charting there. And so this is, they can access this person immediately. And because behavioral health is the universal comorbidity. And so if you're serving a stressed population, there's going to be a behavioral issue everywhere. And so instead of having one person here to serve 7 providers, 8 providers, no, this person is serving 2 providers for a highly stressed FQHC population with a fairly high homeless population. This is my reflection of my conversation with the psychiatrist that I met at Cherokee, named Greg Perry. I love him because he has a past. And his past is that he was a music director for Dolly Parton. And if you go on the web and see Greg Perry, put in Google Greg Perry, you will see pictures of him and Dolly, and it looks pretty cozy back in the day. So at any rate, at some point he decided the music business, it wasn't for him, and he went back to medical school. And now he's the chief psychiatrist there. He does most of his work in video consults, telehealth. And so I learned a great deal in one visit, which is, first of all, telehealth to him is not talking to patients only. It is maybe talking to patients, maybe talking to PCPs, maybe talking to the PCP and the patient, maybe talking to BHCs. In other words, he's doing a full range of contacts. And he said that he can support a practice of 5 PCPs on 2 hours a week of his time, because they have centers all over the mountains of East Tennessee. And what makes that work is he's also available by phone. And so what's very common is, he says, I have 3 usual patterns of involvement in a patient's care. One is I see the patient, their clinician, or both, one time and offer consultation on treatment planning. And that's the most common interaction he has. Second is, he says, I see the patient 3 to 5 times and I prescribe for them. And when I think they're stable on a medication regimen, I pass that regimen back to the PCP. And the PCP prescribes. And the PCPs are willing to do that because they know they can get them on the phone. If PCPs feel alone with this complex psychiatric regimen, they don't feel comfortable and they don't want to do it. But if they know they can get them on the phone, if something goes wrong, they are comfortable. And he says, sometimes I see the patient enough visits to determine that the management of their psychiatric needs can't be in primary care. And so I make sure that they're referred to specialty mental health and that the PCP does not manage their psychiatric meds. And the other piece that makes this work, by the way, is the nurses at both ends of wherever he's talking. And so he has these highly organized folks who are making sure that it's now 7 o'clock or whatever it is, it's now 10 in the morning, and at one end he has all the information he needs to have in advance about who he's going to see next, and in the other end there's somebody making sure that who he's going to see next is sitting right there and it can be turned on and they can be right in the middle of some useful exchange rather than losing time to technology or lack of coordination. This is data